Everyone.
This meeting is being recorded.
Very good evening, everyone. I'm Dr. Venkatesh Karthikeyan, MD Community and Family Medicine Postgraduate Resident from AIIMS Patna. I'm glad to see that around 500 doctors from limbs and rest of the country have registered in today's webinar. In the past 1 year, IMA Junior Doctors Network has organized a series of webinars for the benefit of our junior doctors. In recent times, we have collaborated with the Ministry of Health and Family Welfare, AIIMS Delhi, IAPSM, TAHO, Star Health Insurance, Max Group of Hospitals, Tata Memorial Hospital, Youth Cancer Action Network, FIMA, SNO, and with many such national and international organizations and their faculties. We got excellent feedback that our webinars are helpful for our young doctors, and hence we are continuing our webinar series. On this World Malaria Day, the Indian Medical Association Junior Doctors Network is organizing this webinar on policies, practices, and innovations in surveillance and case management for malaria elimination to create more awareness about this most important topic. The Indian Medical Association is taking pride in welcoming the chief guest for the day, Professor Dr. C.M. Singh sir, who is the Medical Superintendent and Head of Department of Community and Family Medicine, AIIMS Patna. Sir has a vast teaching and research experience of more than 22 years with more than 100 projects as a principal investigator and co-PI. Sir has more than 55 research publications in reputed journals, including the Lancet. Sir is the Vice President of Indian Public Health Association and has been dedicating himself for the development of field of public health. He has contributed immensely to the nation, especially during the times of COVID, by efficiently managing a dedicated tertiary care COVID hospital and by actively contributing to all phases of Covaxin trial. With this very short introduction, I would like to request Professor Dr. C.M. Singh sir to give the welcome address. Over to you, sir.
Thank you, Venkatesh. Good evening, everyone. I am happy to be a part of this webinar about the policy, practices, and innovation in surveillance and case management of malaria elimination on this occasion of World Malaria Day. As you are aware, malaria is an important public health problem. Though malaria is a preventable and treatable disease, it continues to have a devastating impact on the health and livelihood of the people around the world. Recent report from WHO has shown that the burden due to malaria is constantly increasing. The disease burden had increased from 227 million in 2019 to 241 million cases in 2020. This clearly indicates the increasing trend of the disease, which is reflected in the mortality number as well. Understanding the gravity of the situation and need for new advances in malaria control, WHO had declared the theme for this year Malaria Days as Harness Innovation to Reduce the Malaria Disease Burden and Save the Lives. No single tool that is available today will solve the problem of malaria. We all know. WHO is calling for investment and innovation that bring newer vector control approaches, diagnostics, anti-malarial medicines, and other tools to speed the pace of progress against malaria. I believe that this webinar will be an eye-opener and will help us to proceed in that direction of reaching the zero malaria target. I learned that around 500 doctors have registered for today's event. I appreciate IMA Junior Doctors Network, Dr. Anirban and his team, Dr. Venkatesh Anirban and his team, for taking such an initiative, which is a need of our. Along with all other participants, I am also eager to learn from Dr. Kaushik Sarkar, who is apt person to talk on this topic. And I thank you for Junior Doctors Association for giving the opportunity to be a chief guest in this program. And thank you everyone.
Thank you, sir. Thanks a lot for guiding and motivating us, sir. Now I'm glad to introduce Dr. Anirban sir, Assistant Professor of the Department of Community Medicine, R.G. Kar Medical College, Kolkata. I request Dr. Anirban sir to give the opening remarks.
Thank you, Venkatesh, and thanks to our chief guest, Dr. C.M. Singh sir, Professor C.M. Singh sir. And this is a very innovative opportunity for us to have Dr. Kaushik Sarkar is one of the pioneer worker in this No Malaria initiative in India. And World Malaria Day is recognized globally on 25th of April every year with the aim to spread the awareness about the disease, about this disease. This year's theme is just to harness innovation to reduce the malaria disease burden and save lives. If I consider our country, the India is amongst the 6 countries that are most prone to have the infection of malaria. And it has been estimated that malaria impacts 241 million individuals globally in 2020. You know, the COVID impact was completely there. Still, we are having that kind of huge malaria burden throughout the nation, and global scenario is the same. The early diagnosis and treatment of malaria are most important steps, else it can lead to complications or that can be fatal, that can lead to the death. And there are several pockets in India which are actually the malaria endemic zones, and there are some kinds of vaccines are there has come with some kind of policy making. If I consider the journey from the last 15 years, for the last 15 years, we have reduced the malaria burden, but it's not that significant. Dr. Sarkar will help us and brief us about the scenario. And now I would like to invite Dr. Kaushik Sarkar.
So
He's
before
an
that, I would
MBBS,
like
MD, MBA, and I think Venkatesh will introduce with the detail of Dr. Sarkar.
Yes, sir. Yes, sir. Thank you, sir. I take immense pleasure in welcoming Dr. Kaushik Sarkar, sir, who is the founder director of Institute of Malaria and Climate Solutions. Sir is a gold medalist in MD Community Medicine and has completed MBA Business Analytics with distinction. He is a recognized global health leader and serial incubator who aims to benefit the billions health using the untapped opportunities of applying health tech innovations and artificial intelligence through disruptive strategies and transdisciplinary solutions. He has incubated India program of 2 international organizations and has recently led the foundation of Institute for Malaria and Climate Solutions, a global virtual center at Malaria No More that aims to climate-proof global health solutions. Earlier, Sir has led over 30 regional, national, and international research and real-world projects in infectious disease and One Health. He had drafted multiple national strategies, advanced game-changing approaches of targeted interventions, precision programming, and early warning, and convened 3 multi-sectoral platforms in India, engaging both the public and private sectors. Sir is an established thought leader in health security, having more than 20 high-impact scientific publications. He also serves as a mentor to many doctoral and graduate students in multiple universities. With this brief intro, I would like to welcome Dr. Kaushik Sarkar, sir, to take over the session. Over to you, sir.
Thank you so much, Dr. C.M. Singh, sir, Anirban, Venkatesh. It's a great opportunity to talk with so many doctors and medical students on the World Malaria Day. I'm very happy to inform all of you that, after 2015, when the Honorable Prime Minister pledged to eliminate malaria in India by 2030, today in the morning, in an grand event organized by the National Center for Vector-Borne Disease Control and the World Health Organization, the Honorable Health Minister Sri Mansukh Mandaviya ji also pledged to eliminate malaria in India and elevate the fight to succeed in the end game. Essentially, India has reached at a junctional stage where it has another 5 years to reach 0 malaria cases. And we were just completing the joint monitoring mission visit for malaria program review last week to assess the challenges and strengths, opportunities, weaknesses and threats for malaria elimination in India. And we found so many of best practices happening, but at the same time, we we found that there are great opportunities to still intensify the effort and reverse the findings or reverse the history that happened about 60 years back, when after reaching up to 60,000 odd cases, we failed to eliminate malaria in a country like India. Now we are sitting on top of a reported malaria burden of nearly 150,000 cases. My presentation today focuses on a very specific issue related to malaria elimination. And I was earlier talking about innovations, policies, and practices with Anirban. And one of the major paradigm shift that elimination requires, in contrary to control, is the accurate understanding of the malaria burden. So today, as we report 150,000 or maybe 100,000 malaria cases in the country, there are many cases that are happening, that are getting diagnosed in the private sector. There are cases which are happening in weak surveillance areas. We call them surveillance blind spots. And unless we detect those areas and those cases, it is impossible to reach to zero cases, because to reach zero case, the first thing you need is to confidently state that these many cases you have to manage. So the major challenge that actually impedes that progress is the unavailability of tools to detect and to map malaria case clusters, and also enable decision making at the very grassroots level, at the level of district program managers and sub-district level health workers, who can then support or who can then intensify and target their efforts at the grassroots. At the same time, another grave challenge that we are not focusing on, and even in the previous or rather ending malaria strategy or national strategic plan, in which we have not addressed, is the intersection of climate and malaria. Many of the regions which were earlier free from malaria globally are becoming malaria receptive and malaria endemic simply because of the climate change. At the same time, what climate effect is doing, various climate events such as heavy rainfalls, flood, cyclone, and other events, they jeopardize service delivery at the grassroots level. But at this point of time, despite having improved climate level forecasting, where we know what would be the rainfall in the next 7 days, whether there would be any temperature change, we are still not using the climate information to predict the risk of malaria, the incidence of malaria, and also prepare our grassroots level workforce to adapt to those challenges. With those problems in mind, I have a specific presentation in which I'll talk about a prediction and decision tool that we are currently working on in collaboration with the India Meteorological Department of the Government of India and the Government of Odisha, in which we had established the Strategic Support Unit for Malaria Elimination, and also being supported by the National Center for Vector-Borne Disease Control and other organizations. So I'll share my screen. Is it visible?
Yes, sir, it is. It is.
Yes, visible. Thank you so much. So 2 years back, I think I'll stop my video and that will drop this. So 2 years back, in 2020 at the DevEx, we launched an initiative called Forecasting Healthy Futures, which focuses on climate proofing global health solutions, starting with the use case of malaria. And one of the primary reasons of that was the understanding that malaria is the first and most urgent case of inequitable and unequal climate impact and climate injustice across the world. This is the image of Dr. Tedros sitting in one of the high-level UN meetings, where he said that climate change is already killing us. And post that, an op-ed was published stating how climate change is jeopardizing the global fight against some of the most persistent and longest standing diseases such as malaria. Around the same time, the Lancet Commission on Malaria Eradication posted one of the grave concerns, or long-term concerns. In the past 2 decades, the world has seen nearly 40 different countries eliminating malaria. But at the same time, what we have seen is since 2010, malaria incidence has not changed significantly globally. But investments in the past 2 decades have definitely led to the saving of 7.6 million lives from malaria, averting 1.56 billion cases. Now, this particular graph shows what we target in 2030 globally. And the estimate that we see with the current projection, we are way up. So the anti-malarial interventions as well as the national malaria programs need to be climate-proofed and should have resilient health interventions to prevent the change in the course or the upsurges that happen due to local and focal outbreaks of malaria. With that in mind, in collaboration with the Crown Prince Court of Abu Dhabi's Reaching the Last Mile and several different organizations such as PATH, Tableau Foundation, and others, we convened globally an initiative called Forecasting Healthy Futures that housed various organizations from various different disciplines to focus on the policy aspect, to elevate the issue among policymakers and donors about the intersectionality of climate change and health, again starting with malaria, and promote investments in proactive solutions. And secondly, to promote innovative solutions by designing advanced tools and technologies to anticipate and mitigate the impact of climate change on all aspects of health using AI and climate information. Now, the first solution that we designed at this intersection was the Malaria Prediction and Planning Toolkit. As the name suggests, this particular toolkit provides 2 different solutions. One is the prediction aspect, and another is the planning aspect. Here you can see on the left side of my screen the first page of the dashboard of Malaria Prediction and Planning Toolkit system that provides the top line indicators alongside geospatial map highlighting the targets of interventions. At the same time, it also provides information related to accessibility of these hotspots based on chances of rainfall and wind speed, and also highlights the top line indicators of transmission, such as the annual parasite incidence, that is malaria incidence, and the total positivity rate. Now, we carefully designed this particular toolkit to identify malaria hotspots in some of the most inaccessible areas. The toolkit, just for your information, we tried and piloted this toolkit in 15,000 square kilometer areas of Koraput and Malkangiri district to start with, where multiple different challenges exist. One is inaccessibility, second is illiteracy, third is conflict affected areas, fourth is very high burden of malaria. We found that different health program, epidemiological, historical, weather, geospatial, and intervention related information can be clubbed together to provide insights that can enable micro level decision making at the hotspots. At the same time, we identified the need of using advanced modeling techniques, machine learning, and artificial intelligence techniques such as computer vision, natural language processing, and long and short-term memory models to provide information related to the stocks or supply chain needs, campaign timing and targeting, and deployment of health workers. But when we derive this information from complex model outputs, it remains unable, it remains not usable by the program managers at the grassroots levels. So we applied the principle of data-driven storytelling to provide decision support at the grassroots and also at the policy level related to the anti-malarial interventions. Now I'll talk about some of the insights that we gathered, that how climate change and other challenges are impeding progress against malaria. The first problem that we noticed is the different profile of Plasmodium falciparum and Plasmodium vivax infections in the country. If you see the graph at the top, this in the high endemic seasons, both vivax and falciparum malaria increases. But in the low endemic season, in the months when Plasmodium falciparum malaria increases, those months may not be similar with the months of Plasmodium vivax transmission. The reason is simple. The impact of various seasonal factors on Plasmodium falciparum and Plasmodium vivax are different, and the lag periods are different. The second challenge that we noticed is definitely the larger seasonal disconnect with increasing reduction of malaria. As the country is progressing towards elimination, you can see here that P. vivax malaria, it has a complete different tangent compared to P. falciparum malaria, with increasing reduction of malaria cases. And this is also a globally recognized phenomenon where we have seen that countries approaching elimination, it becomes very difficult to contain Plasmodium vivax transmission. The third insight that we found from it is that there is a strong seasonality and seasonal peak, and even with reducing malaria cases, the peak remains constant. While the magnitude of the peak drops, the timing of the peak and the respective proportion increase of that peak remains similar. So essentially that leads to unbalanced transmission of malaria. So all these three problems, the different seasonality of falciparum and vivax, the different trajectories of falciparum and vivax as the country is moving towards elimination, and also the consistent peak of malaria even after its reduction following several different interventions. These are the three major concerns as we approach towards malaria elimination. Based on this early information, we decomposed the malaria trends and found one of the striking insight that we found there is that Plasmodium vivax respond lesser compared to Plasmodium falciparum when same interventions are applied to a particular setting. As you can see here, the graph of Plasmodium falciparum declines steeply after application of anti-malarial interventions such as mass screening and complete treatment, as well as distribution of long-lasting insecticidal nets. Whereas in case of Plasmodium vivax, the decline is way more slower than Plasmodium falciparum. The second challenge that we noticed is that while Plasmodium falciparum has only one peak, Plasmodium vivax has a second small peak around the winter in many high endemic areas. The third challenge that we noticed is the outbreak-prone nature of Plasmodium vivax. As you can see, after the decline of malaria cases, the upsurge of Plasmodium falciparum, the upsurge of Plasmodium falciparum is very small, whereas there can be focal outbreaks of Plasmodium vivax. Based on this, as we mapped the seasonality of Plasmodium vivax and falciparum, we found that the seasonal upsurges are completely different for the two species. Following that, we separately mapped falciparum and vivax with different parameters of climate factors, such as the temperature. You can see even when malaria cases reduce, the gap between peak temperature and peak falciparum malaria, it remains same. So this particular lag, this also exists here while the country progresses to reduce malaria. Similarly, the relation between peak rainfall and peak humidity with malaria transmission remains same. So essentially, while we are applying the major interventions such as early detection and complete treatment, surveillance, epidemic detection and control or outbreak detection and control, as well as integrated vector management, the three core interventions for malaria elimination, these interventions have not changed the course of malaria in terms of its seasonality. We applied time series based forecasting through Holt-Winters model, that is an AI based model, and tried to find out the forecasted cases with a very high level of accuracy. So you can see that more than 85% accuracy was achieved, and this particular forecasted graph is very similar to the actual cases that happened during that period. The next challenge was to aggregate these solutions to an application that is usable at the grassroots and also build capacities. So we worked on automating the workflows, allowed scaling and export of multiple models to build multi-model consensus, because we recognized that the malaria models of the state of Odisha may be different in the state of Bihar, in the state of Maharashtra, in the northeastern region of the country. Venkatesh, my internet connection shows unstable. Can you hear me?
Yes, yes. There is a difference, but it is accessible.
You are audible.
Okay, perfect. Thanks. The third issue that remains a challenge is the data literacy among public health managers. The district vector-borne disease control officers at the district level are not trained to apply complex research outputs into daily decision making. So as I mentioned, we needed to build the capacity of the public health managers at the district level as well as at the state level, and also provide them a decision tool which is understandable at different levels. And finally, another major challenge was integrating the different data sources. To obviate this particular issue of data sharing, in collaboration with the India Meteorological Department and India Council of Medical Research, we convened the Interagency Expert Committee for Malaria and Climate. This particular committee enabled data sharing, or rather seamless data sharing between the health sector and the climate sector, which becomes a huge success which remains intangible till date, but yet a driving factor to enable similar solutions in other areas. Now, while this particular solution was essential to enable decision making and forecasting, we also recognize the challenge of reporting. As the country has enabled integrated health information platform and the piloting is currently going on in multiple states, it is focusing on improved timeliness of reporting and improved accuracy of reporting. But we understood that there is currently no platform for malaria reporting in the private sector. We also recognized that at the grassroots level or at the ground level, no mHealth technology has been applied so far to enable real-time reporting and decision making by the health workers. To achieve that, we identified the need of over 20 additional features that includes user profiling, recommender systems for case management, intelligent chatbot for health workers capacity building, geolocation and geofencing to target interventions at micro level, worker profiling for performance monitoring, and alert and notification system for real-time reporting. This particular technology, alongside the backend malaria prediction and planning toolkit, following its pilot, was launched by the Honorable Health Minister of the Government of Odisha and the Director General of Meteorology of India Meteorological Department, along with the officials from the National Center for Vector-Borne Disease Control on 8th March 2022 in Bhubaneswar, Odisha. And we are planning to export this particular solution across the country and also outside the country. So this year we have launched the Institute for Malaria and Climate Solutions, which Venkatesh just mentioned during his introduction. And through this institute, we will be providing this particular solution. Right now, we recognize 3 areas of support that the countries that are focusing on malaria elimination need. The first one is innovation and original research. Somehow, this has got dampened in the past several years because we don't see many innovations in the field of malaria. And the innovations that come in force in terms of malaria vaccine and newer drugs, they have their own life cycles and they will take their own time to come into the country's program pipeline. Currently, these tools are not available to even supplement any current intervention for malaria elimination in the country. So to develop and refine cutting-edge technologies which does not have or does not require that lead time, we are focusing on such innovations. The second element is to assess the impact of different decision tools and forecasting models for better prediction and planning, and evaluating the processes, because in each of these areas, each of the geographies, the implementation of malaria program happens through different agencies and through different mechanisms. So adoption of this particular solution will require a lot of work. The second area of work is networking and knowledge dissemination. So far, we have convened researchers from 30 different countries who are facilitating exchanges and shaping the research agenda and innovation agenda for malaria elimination. And we are also building implementation support for all the countries focusing on malaria elimination, building tailored solution and ensuring access to sophisticated global data sources, tools and technologies, as well as expertise. I'll not talk much about this, but we have a robust scientific advisory board to support this initiative. And this is the map of the network of experts who are coming from various parts of the world to provide inputs in this particular solution. The vision is to enable better collaboration and formalization of multidisciplinary field of work. This year, we will also host a global scientific conference to promote solutions that are happening in this particular area of work, so that the conventional anti-malarial interventions become climate proof, and that becomes a use case for other health problems in the country and across the globe. Now, to understand the current practices, we will run a global survey of national malaria control programs in Q2 of this year, which will focus to understand the knowledge and attitude regarding climate's impact on malaria, the existing models and systems, quality and availability of data sources and domestic technical capacities. We are preparing for exporting and adaptation of these toolkits in another Asian country, Indonesia, and another country in Sahel, Senegal, starting this year. Now, despite this particular solution, we felt that there are numerous unresolved challenges. What this particular solution will not enable is the private sector reporting issue. Currently, the health management information system of malaria program primarily reports public sector data on reported malaria cases. However, although 32 states have made malaria notifiable, private sector reporting in malaria is very limited. So I urge to the Indian Medical Association to take this initiative to enable malaria notification across the country, and we will be happy to support you to provide a platform to the private practitioners to fulfill this gap. The second issue is real-time notification. While the country has moved to integrated health information platform, due to the unavailability of mobile devices with the ASHAs and the frontline workers, malaria case notification is not real time. But despite this particular challenge, and despite the problem that to enable real-time reporting, India will need similar number of devices as that of the number of ASHAs in the country. That means almost 1 million, which is not in sync with the budget of malaria programming, but has to be taken up under the National Health Mission in sync with the Ayushman Bharat Digital Mission. The third piece of challenge that we see is the urgent need of more sensitive diagnostics. Currently, India relies on microscopy and conventional rapid diagnostic tests for malaria diagnosis. but in several different private hospitals, especially super specialty hospitals, advanced technologies such as polymerase chain reaction are being used globally. Ultra-sensitive RDTs have already been WHO pre-qualified for use in malaria endemic countries. So such solutions are needed to be adopted within the national program, but also in the private sector. At the same time, I also urge the Indian Medical Association to look into the quality of malaria diagnosis that is happening at the private sector, especially in different laboratories. The fourth challenge is related to pharmacovigilance. While more than 30% of India's malaria cases are due to Plasmodium vivax infection that requires long-term treatment, that is 14-day treatment with primaquine, which we call radical treatment. There is a compliance issue and there is a challenge related to the side effect or adverse effect in G6PD deficient individuals. So there is an opportunity for Indian Medical Association to advocate to strengthen pharmacovigilance and also communicate to the large pool of patients that are reporting to the private doctors to improve compliance to radical treatment. And I also invite the India Medical Association to collaborate in the foundational work of this forecasting and refining models to climate-proof anti-malarial interventions, and all the postgraduate and doctoral students who have joined this particular initiative from various different universities to focus on malaria-related projects where you could support malaria elimination through the endgame period of next 5 years that would eventually accelerate India's progress to malaria elimination. With this, I thank you all, and over to you, Venkatesh and Anirban. So thank you so much for this opportunity. Open to any questions, please.
Thank you, Dr. Sarkar. So it's really a nice deliberation, but still we are actually facing a real challenge, though we are approaching towards a better future for malaria elimination. We have few questions in our mind and from several issues. Like, first of all, if you don't mind, we can have a discussion on that.
Absolutely,
Dr. Sarkar?
absolutely
Yes.
fine.
Okay. So first of all, till now, if I consider, there are only two countries which have eliminated malaria as per WHO malaria-free area countries, like China and El Salvador, according to my knowledge, if I'm not wrong. So where the Indian policy lies behind the China, or why China has eliminated but India have not done it? So what's your opinion?
See, first of all, there are, as I mentioned earlier, almost 40 countries have eliminated malaria globally. And if you see the malaria map, Sir Richard Peacham had written a very nice paper several years back, syncing the malaria map globally. And that highlights how investments to eliminate malaria has helped various different countries. Now, we have seen in recent years among our neighboring countries, Sri Lanka and China have eliminated malaria. However, if you see China's progress, for a very long period, China was having very less number of malaria cases. They focused on a 1-3-7 strategy. So the basis of that, or the foundation of that strategy, lies in the fact that you know the accurate burden of malaria, you know where exactly the case is happening, where the malaria foci exist. You are investigating those foci and you are coming up with your response within 7 days. As I mentioned earlier, currently in our country, there is no decision tool to enable such level of programming. However, India's policy has enabled several changes in the last decade. First of all, we have introduced point of care testing through rapid diagnostic test in around in a few years back, and that practice has been scaled across the country. Although this is not the best practice, I would say, but to enable early detection, rapid diagnostic tests definitely have a great role. The second part is the scaling of long-lasting insecticidal nets. Earlier, our country used to focus on insecticide-treated nets, which used to have a life cycle of only 6 months, or longevity of 6 months. However, the long-lasting insecticidal nets, in contrary, have a longevity of 3 years or 20 washes. And the Indian government have procured and distributed these nets to areas where the malaria incidence is more than 1 per 1,000 as a policy decision that was undertaken. And it was supported by the Global Fund to achieve this success in many areas, such as the northeastern region, 7 states in northeast, the state of Odisha, Jharkhand, Chhattisgarh, Madhya Pradesh, parts of Gujarat, parts of Maharashtra, and in some other states. However, there are opportunities to scale, and as I earlier mentioned, the major challenge remains with our notification policy implementation part, which is not happening properly. The second challenge remains with our approach to diagnose malaria. We still rely on tools which are less sensitive, like microscopy and conventional RDT. Third, we still rely on siloed practices at the government and private sector. The policy and the guidelines need to be disseminated to the private sector at the earliest. And finally, at the policy level, an urgent need is there to promote the innovation pipeline related to drugs, diagnostics, and insecticides, because in many different parts of the world, some tools are being used which we still don't have access to.
Yes, thank you. Thank you for the clarification. Another thing, there may be a doubt or some kind of questions from the juniors along with the general physicians altogether. The WHO has given the approval for malaria vaccine.
Right.
Is India is quite eligible, or there is any need of malaria vaccine in India? What is your opinion?
Malaria vaccine is not a new tool per se. So globally, research is happening for the almost last 30 years or even more than that to develop a malaria vaccine which is effective. If you see the current malaria vaccine, it focuses on very high endemic areas, Plasmodium falciparum predominant areas, and in child cases. But if you see the epidemiology of malaria in India, we have a fairly equal proportionate distribution of malaria across different age categories. India is not similar in terms of epidemiology to the African countries, where the API is way more higher, or total positivity rate is way more higher than in India. And the third issue is that this vaccine has limited effectiveness, for which, if you think of the cost effectiveness part, investing in malaria vaccine and investing in other different solutions, such as the long-lasting insecticidal nets, the indoor residual spraying, the better diagnostics, mass screening, and other strategies, which are also cost-intensive strategies, but those strategies have more near-term impact compared to the vaccine, given the epidemiological setting that our country has. Having said that, there are at least more than 15 different candidate vaccines which are being tested and tried. And I am aware that at least one malaria vaccine is currently being tested, which focuses on multiple different stages of malaria. If such vaccines are available, I believe there will be more effectiveness in terms of applying vaccines. And also other technologies such as monoclonal antibodies are coming up. Earlier last year, monoclonal antibodies were tried with promising results. So these two tools can later be effective, but it requires a lot of research, and India has only 5 years to eliminate malaria.
Very informative for all of us, and I think most of the doubts have been already cleared. So my last question for you for this session, sir, if we want to get this elimination as soon as possible, we can achieve it. But you know that from your presentation we can understand that we can achieve it. But how organization or like how an organization like IMA, you have already mentioned though that IMA can involve in this elimination program, as well as there are such several associations, including the general practitioners. So where their role can be light, and secondly, what kind of actions can IMA take to help the government to get the elimination? Please.
Right. So first is the opportunity part. Second is the actionable element part. So when I talk about elimination, I talk about 3 levels: policy, practice, and public. Fortunately, and this is a very great aspect, that the Indian Medical Association has strong voice in all the 3 different levels. At the policy level, as I mentioned earlier, India's last update on the guidelines for malaria diagnosis and treatment happened around 2013-14. India launched its malaria elimination campaign in 2016, following the Honorable Prime Minister pledge to eliminate malaria by 2030 in 2015's East Asia Summit. There is an urgent need to review the diagnosis and treatment guidelines and find out the existing gaps related to early detection, treatment completion, therapeutic efficacies, pharmacovigilance, and many other aspects which are trivial but becomes critical when it comes to eliminating malaria. For example, in our country, the formulation that is used for the treatment of pediatric or infant malaria, that is not suitable for infants. Similarly, better treatments are required for radical treatment. All these issues need to be addressed at the policy level, where IMA has a very strong voice. IMA has played very critical role during the COVID-19 pandemic, and it has essentially made many discourses that led to disruptive policy decisions that helped the country achieve early containment of the COVID-19 pandemic. Right now, IMA needs to have a very strong voice for malaria elimination. The second part, related to the practice level, is the practicing physicians who are currently working. They also have the responsibility and accountability to notify malaria cases. Once malaria cases get notified to the local public health department, then only actual action based on malaria incidents can be undertaken. If you see India's national strategic plan, all the anti-malarial interventions are tailored to malaria incidents. However, if we don't know the actual incidents, we can't tailor those interventions properly. So precision programming requires active participation, and with IMA's directory and membership of so many medical practitioners and physicians, it is possible to mobilize the private practitioners, the general physicians, to notify malaria and also align with the guidelines for malaria testing and treatment. The third piece that I understand here is the integrated management of febrile illnesses. See, COVID-19, malaria, enteric fever, dengue, and many other illnesses in the country which are posing health security challenges. The cardinal symptom is fever, and the patient comes to doctor with only fever and associated symptoms. When a patient is coming to the practitioner for fever, there need to be an integrated policy for managing all the febrile illnesses. The country has a provision for integrated management under the IDSP, Integrated Disease Surveillance Project or Program. However, at the private sector and also at the government sector, there is an urgent need to integrated fever management. Lastly, at the public level, so I talked about policy and practice. Lastly, at the public level, the interface between public and the doctors is the point where communication, health education happens the best. We have to accept the fact that still, despite many different issues related to patient-doctor relationship in this country, the reliance of the patient still is there on doctors' voices and doctors' key messages. The health education the doctor can provide, no one else can provide. So India Medical Association can proactively drive their members to drive those health education messages and key messages, which program the national program has been trying to deliver for so long time. The non-profit organizations and the partners are trying. So all these three levels of areas, we need Indian Medical Association's action, and through their members and through their leadership, both at the policy and practice level and also at the communications level with the patients.
Thank you so much for this excellent clarification. Rather, I think it will show the path towards the elimination for IMA, the organizations like IMA. We have few more questions. If Venkatesh allow me, we can have. Yes. So there is a tricky question: the TB versus malaria elimination from Muhammad Kasir. Which is more challenging? Dr. Sarkar, if you answer it very briefly, whether this elimination of malaria is we are progressing faster than the elimination of tuberculosis. What's your opinion?
I would make a tricky answer as well. So just compare the number of countries that have eliminated tuberculosis and malaria in the past.
Exactly.
You'll get the answer. And another response is that, we all know, who have learned epidemiology, we all know that eliminating an acute illness is way more easier than eliminating a chronic illness. Both are very difficult. Both are longest standing diseases in the country. However, I believe the feasibility of malaria elimination is more than the feasibility of tuberculosis elimination, while the country's target is different.
Yes.
Based on various other factors.
Yeah. So the last one is what's your take on drug resistance malaria? It is by Dr. Pavitra M. Another one from Dr. Arihan Chen. The 6 maximum malaria cases. Okay, the malaria cases are more in tribal, forest, and terrain regions. So how do we tackle to control them, along with preserving their culture? Okay,
right.
So these 2 questions. Yeah, please.
So first of all, drug resistance malaria, if you see the World Malaria Report 2021 and the recently published studies on therapeutic efficacies, although there are a lot of discussion around emerging mutations that promote drug resistance, treatment failure, which is the primary factor or which should concern the public health managers, and the doctors, we have noticed that only in the northeastern region of the country. And accordingly, the Indian government allowed the use of artesunate combination therapy with artesunate lumefantrine combination in the northeast and artesunate sulfadoxine pyrimethamine combination in the rest of the country. Just to, for the sake of interest, because I have noticed during my review also that many different practices happen in terms of malaria treatment. We should provide chloroquine and primaquine for Plasmodium vivax, uncomplicated Plasmodium vivax, and in patients with who are not infant or pregnant women. And we should provide artesunate combination therapy to Plasmodium falciparum malaria cases. Injectable artesunate monotherapy is banned in the country. It should not be used. It promotes drug resistance. Chloroquine for Plasmodium vivax and ACT for Plasmodium falciparum is still very, very sensitive, and we don't have any reports yet from credible organizations related to resistance to these drugs. Please note that there are not many reserved drugs to fight malaria. Use these drugs cautiously and as per the National Treatment Guideline 2013.
Yes, and the second one?
The second one is related to the tribal forest and terrain areas. See, 80% of malaria occurs in these areas, tribal forest terrain areas. And the primary reason is that these areas are marginalized and inaccessible, receive limited services. At the same time, there is vector abundance, and you can't actually cut down the exposure to malaria from infected vectors much in these areas. So at best, what can be done in these areas is to improve access. If you see some of the best cases that has happened in this country, in the northeastern region, in the state of Odisha, some parts of Chhattisgarh, and in other states like Madhya Pradesh, they have tackled these problems with different strategies. The first one is, if you can't strengthen the routine surveillance in a surveillance dark area in a forest and hilly areas or areas with shifting cultivators, just focus on focal screening and treatment. Camp-based screening of a population and treatment. Active surveillance becomes the mainstay of malaria control. In these, active surveillance and management remains the mainstay. In these areas, you can't rely on ASHAs because you can't expect the patient to travel 10-15 kilometers through the forest to reach to the ASHA's house to report his or her malaria. So when, you know, the patient cannot come to the health facility or the health worker, it is the responsibility of the health system to reach to the doorstep of the patient. And that's the mechanism of active surveillance. So there is an urgent need of active surveillance. The second is, in these areas, there are a lot of reliance on unqualified medical practitioners. And they practice indiscriminately. And because of those practices, what happens is there are increased risk of anti-malarial resistance. Often patients are not properly treated, diagnosed, and even unknown deaths happen. So in these areas, there is an urgent need to apply the General Physicians Network of Indian Medical Association and promote this particular network at the small districts or sub-district level, so that this particular network can actually manage the large bulk of fever cases in these areas. Once that happens, the patient will get quality treatment. If some areas are truly inaccessible, we need to activate volunteers. For those, you need to identify local tribal people who can be trained. And these capacity building initiatives can be undertaken by the local physicians or the groups of local physicians, and also IMS district level units.
Thank you so much. Thank you for highlighting. All these points have been covered, I think. I must thank you, from the bottom of my heart for taking your time from the busy schedule. And your presence and wise words helped us to magnify our cause in best possible way, I guess. So thank you so much, and I must be thankful to Venkatesh also, and I must be thankful to the organizer, like IMA headquarter as well as Clarinet. So over to Venkatesh.
Thank you, sir. Thank you, sir. Thank you, Kaushik, sir, for the excellent session. Hope the knowledge gained from this webinar will be of immense help to amplify. Just so am I audible now? Yeah.
Yes, your voices are coming, but there's echo.
There is an echo happening.
Okay. Okay, sir.
No problem.
Yes, sir. Yes. So, sir, I hope this will be of an immense help to junior doctors and aspiring public health specialists. So, thanks a lot, sir. Despite your hectic schedule, you have spent time, and especially
Thank
today
you
is
so
Monday
much.
Day. Many people would have been approaching you for webinars, but still you chose to be a part of our webinar. Using this opportunity, I would also like to invite the audience to our upcoming JDN event. Tomorrow at 6 p.m., we have a session on ophthalmology revision for NEET PG and INICET aspirants by Dr. Rajratna ma'am. You can find the registration links for the events in IMA JDN Facebook page, Instagram page, as well as in my personal profile. So once again, I would like to thank Dr. CM Singh sir, Dr. Kaushik sir, Dr. Anirban sir, and all our 500 plus participants for making this webinar a grand success. Thanks a lot, everyone. We are closing now.
Thank you.
Thank you so much. Thanks.
Thank you. Thank you.
Thank you so much. Good night. We're closing here.